1, 2. Good morning, everyone. We noticed that it's about time. I would ask another 5 minutes. Maybe we will have a few more people in the room, so please bear with us for another 5 minutes and then we will start. Thank you. Good morning, everyone. Good morning again. I guess everybody was so excited of having a union face-to-face meeting that they disappeared and went to discover the city, probably. But we are super happy to have this big room on all of us for this important topic. We are here today to discuss a bit about community rights and gender, and how we can eat it, right? Because I remember, and I see in the room a few NTP managers, and I appreciate very much that you joined our discussion today. One of my friend, NTP manager, after several times applying to the Global Fund, writing nice proposals and so on, the proposal was rejected by the TRP with huge recommendations to address community rights and gender. So he came and said, it's like, Viorel, what is CRG? I wanna put CRG there. I don't know what to include there. And then we realized that we need to discuss. We need to agree. We need to document, because a lot of people don't know what does it mean CRG and don't believe that CRG works. CRG meaning community, rights, and gender. And here probably to set up the scene, because we have amazing speakers today, I would say that imagine a country with extensive mining sector. Miners goes in the morning underground, and they come up in evening, late evening. If they need medical services, they can get those services after work, right? And if the clinics works only from 9 to 5, most likely they will not access those services, right? Simple. If you imagine urban population and people are working paid by hour, if they are paid by hour during the day, they most likely will not go and get services because they lose income. Those services need to be provided after work, after their work. So this means to have people-centered care, right? This means CRG for us, because it's from one perspective, it's a right of them to have services. From another perspective, the services should be tailored to their needs, right? And we are coming to the needs. How do we know those needs? Because we need to tailor our services. We can have the best health system in the world, excellent, with like last technologies possible. A lot of people will not come because of human rights barriers to services. And this is why we are bringing CRG on the table all the time when it is about tuberculosis. So when we talk about needs, who can tell those needs? People. It's not us to guess, right? We need to ask them. We need to engage them. We need to understand those needs, because we need to tailor the services for their needs. So we need to engage those people that need services to understand better their needs. And here it comes the definition of key and vulnerable populations. Why we are saying key and vulnerable populations in tuberculosis? Because there are populations that need specific needs. Very simple. And then we need to identify them, to prioritize them, because different countries are different. We need to prioritize them and tailor the services for their needs. So this is what CRG about when we talk TB. So I guess I will stop here and will ask my co-chair and good friend, Karamsha, to take on from here. Thank you.
Thank you very much, Viorel. Very good morning. Needless to add any more on the background of what CRG is. Viorel is a master of this subject, and Stop TB Partnership is the lead organization working on CRG. Today we have a panel of excellent presenters working from the global level perspective, giving Kiva, and then we have our two very young presenters who would give us some insight of their work on CRG and community work in the countries, and then something about the work and the complementaries of the technologies over this work. So let's start with our first presenter, Kiva Smith. She is from Stop TB Partnership, so please. So she has been working on CRG and Stop TB Partnership for the last 8 years. Kiva, over to you.
Can you hear me now? Yes. So good morning, colleagues. As Dr. Karam Shah mentioned, my name is Kiva Smith, and I'm a Community Rights and Gender Program Officer within the Stop TB Partnership. And it's really a pleasure to be with you all at the Union Conference this year, in particular that we are together in person rather than online. It is also a pleasure for me to be part of this group today that's here to discuss community rights and gender and how it has come to be that it has become a central intervention area in the TB response despite limited resources. So I guess the first important question to answer is why and how has it become an important area of intervention? Well, in a nutshell, it has really become a pathway towards systematically identifying the key and vulnerable populations, to systematically identifying, understanding the barriers to access that these populations face, and also to systematically overcoming those barriers to access. So in other words, community rights and gender has become an important area of intervention because it is proactively and systematically finding those missing people with tuberculosis. So to support this area of work, the Stop TB Partnership, in response to the calls in the original global plan to end TB to focus on key and vulnerable populations, we started asking ourselves, together with you, okay, so who are those missing people with TB? Who are those key and vulnerable populations? And what are those barriers to access? Now, while we might have known that already, what we also knew is that we did not have the evidence to support targeted interventions to reach those key and vulnerable populations in order to be able to overcome those barriers to access. So as a starting point, the Stop TB Partnership, together with affected communities and human rights and gender experts and NTPs, developed what we now call the Community Rights and Gender Assessment. And it is a qualitative assessment tool that relies on community leadership and participation and collaboration with communities and NTPs to start to break this down, to start to understand who are these key and vulnerable populations, why should we prioritize them, what are those barriers to access, and how can we overcome those barriers to access in a systematic way. And the outcome of that process was not just the generation of the evidence that we needed, but I think what was particularly important is that we started to be able to demonstrate the importance and the value add of community leadership in the TB response and the importance of that partnership between communities and NTPs. So since 2018, I think the progress that has been made at the country level has been significant. Over 30 countries have now conducted community rights and gender assessments. So we now have this evidence base for evidence-based CRG interventions at the country level. As a result of this evidence base, these 30 countries are now, in addition to others, are now in a position to be able to implement community rights and gender interventions, again, that respond to the evidence and that rely on the 7 dimensions of the right to health. In other words, communities and together with NTPs are now working together to understand and to overcome the barriers to access, to ensure that TB services are available, that TB services are accessible, acceptable, and of high quality, free from stigma and discrimination, that are protecting and promoting the right to confidentiality and privacy, and ensuring that we are being responsive to the needs of all genders. As a result of all of this work, what we're starting to see is the institutionalization of community rights and gender in the TB response. Over 15 countries now, that we are aware of in any case, have national costed CRG action plans integrated into NSPs. In addition to that, we've been able to support 9 countries to mobilize affected communities to engage as equal partners in joint TB program reviews. And as such, CRG has become a thematic area within the program reviews and thus the TB response. In addition to that, we now have over 30 countries that have committed to institutionalizing community-led monitoring in the TB response. And I think most importantly, because of all of this work, because it is community-led, we now have affected TB networks working in countries, driving a TB response, leading a TB response in collaboration with NTPs. This work is, however, still nascent, and we know that we need to do more. Now, all of this work that I have just mentioned, and I know that there is so much more happening in terms of CRG, but all of this work that I have just talked about has been possible because of the Challenge Facility for Civil Society. So the Challenge Facility for Civil Society, as many of you will know, is the Stop-TB Partnerships grant mechanism to initiate, to scale up, to institutionalize community rights and gender in the TB response. And without it and the support of USAID predominantly, as well as the Global Fund, and now l'Initiative, operated by Expertise France, we are now in a position to be able to support 114 organizations across the globe to do community rights and gender in the TB response. And I say that the importance of this is also because without the Challenge Facility for Civil Society, we would not have been in a position to work with you to, number one, develop community rights and gender research tools, to develop tools to support the operationalization of community rights and gender, to provide grants to do this work, to test these tools. So the significance of the Challenge Facility cannot be undermined at all with regards to CRG in TB. I wanted to mention very briefly some of the tools that are available for those of you in countries that are interested in doing this work, because needless to say, we would love to be able to support more and more and more countries to do this. So here are some of the CRG assessment tools, the research tools, namely the CRG assessment, the TB stigma assessment, the key and vulnerable size estimation tool that is going to be launched tomorrow, the community-led monitoring framework. In terms of CRG implementation tools, there are so many, but I've just mentioned issues around how to implement gender-sensitive and gender-transformative activities in the TB response. The legal environment scorecard, also to be launched tomorrow, and the Declaration of Rights of people affected by TB. We also have investment packages to support the articulation of interventions in the likes of Global Fund proposals and so on and so forth. We also have a technical assistance program which accompanies Challenge Facility grantees should that be required. However, it is through the Challenge Facility for Civil Society that we really see the technical assistance being operated, because it is the communities that are doing the work. It is the communities that are learning, and it is the communities that are informing the global CRG agenda. So let me conclude on a more somber note. So as we have seen from the recent global TB report, we are still consistently missing millions of people affected by TB. And I think one of the reasons for this has to be that we are not investing enough in community rights and gender for TB. And therefore, we are not maximizing the power of communities to really instigate change at the local level, and the power of community and NTP partnership to really advance community rights and gender in TB. But I will hand back to my co-chairs, and who will introduce our next speakers, who will actually show how they have done it, how they have made that change, that paradigm shift in Pakistan and in Nigeria. Thank you all.
Thank you, Kiva. Thank you, appreciate very much. Yeah, before going forward, just to mention that there is a QR code that you can scan and pose your questions, and I will receive them here, and we may address them. Other than that, we sure can do live interventions as well. Thank you very much. Next speaker is our best friend, Kinza. She's from Pakistan. She is a great leader. She is the CEO of Dopasi Foundation. Excellent partnership manager, can bring all partners at the table, and what is interesting, they can agree together. And we observe this all the time. She is a passionate supporter of the community rights and gender activities, and one of our champions in the Challenge Facility for Civil Society Network. Kinza, over to you.
Thank you so very much. Thank you. Thank you, Dr. Viral. So before we begin, I would like to ask a series of questions. And any question you feel that the answer to you that is yes, I would request you to please stand up. If you have ever missed a day of work because of a health-related issue, please stand up. If you worry about contacting a virus, please stand up. If you have experienced stigma of any nature, please stand up. If your child has ever faced a day off school, please stand up. If you have ever visited a health facility and got a facility is like closed, please stand up. If you or someone you know has suffered with a disease that had a long treatment, please stand up. I'll just request you to look around the room. This is the suffering a person with TB faces every single day. Thank you so very much for participating. You can please take your seats. People sitting in villages, when they start coughing blood-stained sputum, they are sort of convinced by the community to think that they're jinxed. Especially women, they're thrown out of their houses. They're said like, you will bring bad luck to us. This is because of the decades-old stigma that is associated with the disease. As Kiva mentioned, TB is deeply rooted. It has social impact. It is associated with legal barriers. It brings with us structural barriers. It brings social barriers that prevents a person's access to care, prevents a person's approach to the care, their acceptability of the care at times. And this leads us to the Global Report 2023, recently been launched, and most of us have seen. We're still missing more than 3.1 million people affected by TB who are unable to access care. We're losing 40 million precious lives. That means 3,500 precious lives every single day. Studies says that 42 to 82% people with TB face stigma and discrimination, especially the key and vulnerable populations. People with TB face human rights barriers, as Kiva mentioned. A vast majority are not even aware of their own rights. What's even more scary is a great percentage of healthcare providers, they are not sensitized on patient rights. They don't know if, for example, if I'm going to somebody with my husband, with my father, they're going to release my disease status in front of them without caring about my privacy, without caring about my confidentiality. At times we see in facilities, people make people affected by the disease sit out of the room thinking they're contaminated, they're going to bring the disease to you, rather have the parent or the husband step inside of the room. What is the message that we're leaving them with? Then we say that a person is being stigmatized. So obviously it's starting with us. We somewhere, somewhat are leading to that. To close this deadly divide between TB commitments and TB realities, a paradigm shift is necessary. This inspired a focus on community rights and gender, as my colleagues have been mentioning. Community rights and gender need to be at the forefront of the TB response, now more than ever, to find the missing people with TB. Now let me take you back to where this all began, leading to where we are today. We started thinking right after the UN high-level meeting in 2018 and the political declaration that came out, it was evident that to move the needle forward, something different is necessary. We need to change the paradigm. And through the support of our colleagues from the National TB Control Program, our partners, Stop TB Partnership, we together got 100 people from all the range of life. Dr. Ghafoor was there, he must remember, Dr. Lake was there. We collected people from different human rights activists, media, people affected by TB, to come and discuss what are the barriers that we are facing. Why are, despite the investment in diagnosis, despite the investment, TB care services are available in our country, literally across the country, free of cost. But still, the utilization rate of diagnostic tests at times is a challenge for us. So we go like, what are the challenges? What are the gaps to develop a way forward? The outcome of this was the start of a nationwide movement of TB Care, My Right. This routed the attention of policymakers towards a right-based TB response, integration of high-level meeting targets into the national and provincial strategic plan, and adding the voices of the community for the first time in Pakistan to our national response, to guiding the policies in the country. We needed to identify and reach the key vulnerable populations, those who have an increased exposure to TB because of where maybe they live or work, an increased risk because of the biological factors, or a limited access to quality TB care. We accordingly initiated screening among coal miners, returning coal miners, prisoners, transgenders, healthcare workers, refugees. Now we are initiating a formal key and vulnerable population size estimation, which is required for us to know the vulnerability and the size of the populations. And then we can accordingly form the targeted interventions in accordance with the vulnerabilities of these populations to ensure quality care for all. Taking a wider lens, community at large needed to be engaged. They needed to be empowered and made aware about TB, where they can report the barriers if they're facing any. Because, for example, if I go to a facility, I see the facility is closed, I don't have anything where I can sort of say the only option I'll have will be to go to the facility next day and maybe take a day off work again, which might not be possible and hindering my access to care. So to provide a platform where they can report the barriers, or if their right has been breached, we accordingly adapted and launched the One Impact. Our worthy national manager has been supporting us like anything with the community-led monitoring from the day one. He was part of when we first adapted this like years back. And we wanted to launch the One Impact approach to systematically mobilize and engage people with TB, and commenced with the collection of data on barriers. We thus engaged with the district TB coordinators as the first responders, the national and the provincial TB control programs. Furthermore, right now, the One Impact dashboard, it's providing useful insights and data that can be used for future policy making, knowing in what geographical area, what facilities we are facing, what kind of barriers. For example, if a facility has expired medicine and we're getting a couple of reports, we'll write to the district TB coordinator that this is what we're facing, this facility has so-and-so challenges, can you please look into it? If a barrier is not resolved at the facility level, we can take it to the provincial program. If not, then national program. Our national manager has kindly agreed to make CLM a part of our national monitoring and surveillance system, and he said that a slide on this will now onwards be presented at the interprovincial meeting that we have, in which all the programs and all the provincial programs and partners come together. So thank you so very much for that, sir. this all is required for placing community literally at the heart of the TB response and future programming. For people to realize their rights, for people to know their rights, for people to get engaged even with the platform and have access to the platform, mass engagement was required. So we accordingly started mass engagement. We went to TB care facilities. We have these QR codes displayed across certain BMUs, the basic management units of TB, so that people can really download this. Now, thanks to TB Reach, we have these QR codes on the preventive treatment cards as well. So the TB cards that a patient get when they are, on which they refer to on which their diagnosis and everything is run, they have this right there, and they can access the app. Diving deeper, it became known that what provisions are available in our constitution to protect our rights of people affected by TB. Unfortunately, the Constitution of Pakistan does not allow for we don't have a right to health. However, we have the right to life, and Pakistan is a signatory of various UN declarations that provides a safety net. We did a legal, environment, and human rights scorecard assessment, and now we are advocating for inclusion of adequate legal measures for protecting people with TB. To make all this possible, we advocated at the highest level to ensure that community rights and gender are prioritized. We started with the program, with the provincial ministers, with the parliamentarians. We have an NTB parliamentary caucus that has more than 25 parliamentarians from all across the country. We reached out to His Excellency, the President of Pakistan, and the First Lady. We wanted to institutionalize this work, like working in certain silos, working here and there, wasn't bringing that result. So thanks again to the national program and the support from Dr. Viral, who championed this, and Kiva, who came all the way to Pakistan. Through this advocacy, this community engagement was added as a thematic area in the Joint Program Review Mission 2022 for the first time in Pakistan, rather for the first time across the globe, maybe, because only a couple of countries have this. And parallel to that, we did a comprehensive community rights and gender assessment that led to the development of Pakistan's first National Action Plan on Community Rights and Gender, 2024 to 2026, and the recommendations were accordingly included in the National Strategic Plan and the Grant Cycle 7 request. More than 4,500 people affected by TB from across the world, across the country, participated in this assessment, and the voices of the community were made part of the Joint Program Review Mission reports, the National and Provincial Strategic Plan, and the Grant Cycle 7 accordingly. This is the beginning of the implementation. In the last 2 years of rolling this out, we have been able to engage 5 million people. That is a staggering increase of 4,900%. We started from one district pilot in Rawalpindi, and we have increased to more than 17 districts now, and we are sort of moving across the country. Just a known statement, what got us here won't get us there. Based on the impact we're getting in Pakistan, Nigeria, as Dr. Stephen will share, and a few other countries, the objective of us coming together was to advocate for this change globally. We believe that in order for us to reach our 2030 targets, we have to go beyond the normal framework of work that we have been working. We have to go beyond borders. We have to work together. We have to support each other in achieving the targets. Because what got us here won't get us where we need to be to end TB by 2030. We need to systematically identify and overcome barriers, collaborate with the affected communities, ensure community engagement throughout the cascade of care, ensure TB care services and support is available, accessible, acceptable, and of high quality for all, particularly the key and vulnerable populations. We need to collaborate with the affected community. As my activist group says, and one of our champions from Ukraine is also here, nothing for us without us. If it is for the communities, it should be. Community should be at the lead. Community should be part of the whole cascade of care. We have the capabilities. We need the capacity. And here is where all of you come in. We have the right tools. We have the right people. We have the evidence that this works. What we need is the capacity. We need a capacity to deliver. Only a fraction of money, even today, even in the Grant Cycle 7, only a fraction of money is going to community rights and gender. After all the assessments, after everything that was done, after everything that was written in the Grant Cycle 7 request, the money allocated is 0.02% or something. It's hardly $7,900. With this kind of fraction of money, it's hardly, I think, 0.4% in Nigeria. So partial commitment will only bring partial results. We need to institutionalize these efforts. Funding and empowering communities need to receive the same importance as investment in diagnosis. We need to magnify this implementation. Together, we can reach the finish line, and CRG is the way forward. Now is the time to act, because it's high time to put a stamp to NTB. I showed this picture to you in the beginning. Now she's treated, she's having a flourishing life, and she's a prospering part of our community. She's one example. Let's make it real for many more, and let's make it real fast. Thank you so much.
Thank you. Thank you very much, Kinzo, for a very excellent presentation. So on my right side, we have Dr. Stephen John from Nigeria. So he is another excellent activist of CRG, not only in Nigeria, but he has been supporting Stop TB Partnership in different countries, offering them technical assistance in CRG assessment. Stephen, please.
Thank you very much, the organizers, and the chair, and the panel, and of course, the very wonderful audience. I'm going to speak about, when I say CRG, you know it's about community rights and gender. The implementation in Nigeria. We will look at successes, challenges, and the lessons we've learned so far. I have no conflict of interest to declare. I have a short outline from background. We'll look at the successes, challenges, and then we conclude and see what lessons we've learned as well. It is already known that Nigeria has the highest TB burden in Africa. It's sixth among 30 high-burden countries globally, and it is also listed among 14 countries that share in the burden of TB, MDR-TB, and TB-HIV. 59% of people with TB were missed in 2022. And of course, we've heard already something about KVPs from the previous presenter. Key and vulnerable populations often live in poverty, they're marginalized, economically and socially excluded. So because of the reasons that have been given in the previous presentation and what we have here, we're thinking that missing people with TB are likely to be among KVPs. Our quest in Nigeria to address its low TB case notification from the past, where we started from 27%, though we've had some increase, stimulated the urge to implement new strategies and interventions targeting key and vulnerable populations, among other groups. But despite all this, CRG-related barriers to access TB services were largely unaddressed, despite the evidence that optimal TB prevention and care cannot be achieved without addressing these barriers. So as a build-up to Nigeria's first CRG Coastal Action Plan, which we support in its development, we conducted these three basic assessments that happen in other countries, like we heard from Kiva: the legal environment assessment, the TB gender assessment, and then the key population prioritization or rapid assessment. So we had some very valuable findings and recommendations from this assessment, and these informed the development of Nigeria's first action plan, which is funded by Stop TB Partnership, thanks to, again, Challenge Facility for Civil Society for this. So what is expected after this plan is for stakeholders to key into it, to proactively implement these interventions that will address these barriers that we're hearing of today in this particular session. So I'm going to present the results from the just recently concluded midterm review in Nigeria. And this presentation is going to go in line with the 8 areas that has been presented by the first presenter. I start with governance. Nigeria has produced all the 3 CRG assessments in addition to a stigma assessment. The stigma assessment was presented yesterday in another session. Community-led monitoring through the One Impact Act has successfully been piloted and adopted, of course, to context. CRG Action Plan for TB Care and Prevention in Nigeria has also been developed, as I've said in the previous slide. In the area of accessibility, availability, acceptability, and quality, what we refer to as AAAQ, TB patients have reported care quality to be acceptable during that particular exercise. And care accessibility has greatly increased in recent years if we compare with what obtains in the previous years. So most MDR TB patients receive nutritional and transport support. And in the area of information, communication, knowledge, and awareness, we observe that campaigns to improve TB knowledge are widely occurring, and so are availability of IEC materials at service delivery points. In the area of stigma, of course, the conduction of the assessment, it's a plus for us. Then under freedom, the respect for privacy and confidentiality by healthcare workers seems common in facilities that were visited. Then under gender, we're receiving disaggregated data. These are collected and reported. In some cases, even, they're used to identify gaps. Under the area of remedies and accountability, the One Impact CLM approach was adopted and piloted successfully in one of the states in Nigeria, Lagos. Key and vulnerable populations, a range of KVPs are currently receiving services, in addition to people living with HIV in children who receive specific care across all states. We have several examples here. Services targeting correctional facility inmates, nomadic people, internally displaced persons, refugees, slum dwellers, and orphan children. A number of best practices also come out from these particular exercises, especially for refugees, for IDPs, and for the nomads. There are other key achievements, from the One Impact that was implemented in Lagos, just one state, but it was remarkable. Over 50 healthcare workers and TB survivors were engaged. We have organizations also involved in the One Impact accountability platform. We have over 40 community gatekeepers that were equipped with information through One Impact. And One Impact TB support group established also across the state, which was very important. We have some numbers. Over 11,000 children and teachers were sensitized through school sensitization program using One Impact. 3,400 plus people engaged and then active users. Then we have over 1,000 children also put on TPT, and TPT has always been a huge challenge up till now. Over 300,000 people were reached with information via social media and mass media communication. Then we also have over 1,700 people who are put on people on treatment, sensitized on TPT, which is very important because of the rejection and the denials that are being experienced across communities. We have also this same number actively using the One Impact to report human rights violation, which is key. So I take an example of the impact of what CRG can do in one community. This is the refugee community in Nigeria, and we're talking about refugees from southern Cameroon that were expelled, and then they are now settling in parts of Nigeria, in the northeast. So this is a community that has never had contact with TB services, but courtesy of the Challenge Facility Round 9, that was where they had the opportunity to come face-to-face with TB services. And of course, this service was not just the normal TB services, it was integrated with community right and gender solutions or interventions based on the National Action Plan that was developed. So you can see from immediately we just started enrolling out in this community, over 300 cases were found, almost every quarter. It kept increasing. But at the end of round 9, there was a short break, so that's why you have the diffraction to 350. Then Challenge Facility round 10 came, and there we had an operational research component integrated into round 9. We're beginning to use the results of the CRG to improve case finding, and you can see there we had an increase, but unfortunately, after the third quarter of 2022, there was a kind of a conflict because the security agents from neighboring countries were chasing the refugees into Nigeria, and that kind of slowed down the intervention. But again, we're happy that we have an extension of round 10. to conclude some of the operational researches that we've been implementing, and then cases are beginning to come, so the intervention is picking up among the refugees in Nigeria. So what are the challenges? Again, I'm going to present the challenges according to this particular 8 areas. So under governance, CRG Action Plan for Tuberculosis Care and Prevention is not yet fully operationalized, and that is very important if we have to make the impact that we desire. There's inadequate knowledge of CRG approaches among TB program managers and implementers. There's limited domestic funds, as we've heard already. We're talking of less than 1%. Under AAAQ, TB counseling mainly happens at the beginning of treatment. This is something that should happen at every stage of treatment. There's inadequate assessment and response to individual psychosocial patient needs. I'm talking about mental health here. Nutritional support for TB patients is not actually extensive. So we found out that hunger is a key barrier to treatment completion. Ancillary medication is still drawing down on out-of-pocket expenditure for TB patients. Information, communication, knowledge and awareness area, we have knowledge gaps, including misconception, beliefs about TB among healthcare workers and volunteers. And these are the drivers of stigma. And under stigma, we have the misconceptions, the beliefs about TB, and the narratives are culturally inspired and they vary by context, which makes things very difficult. That means you cannot have a uniform intervention. You have to have an intervention that aligns with the local context. It encourages non-disclosure, and women especially are particularly affected more. In the area of freedoms, there were breaches of privacy and confidentiality, and they occur to some extent in some of the facilities that are visited. Under gender, we've seen how gender inhibits care access, especially for women, in contexts which are highly patriarchal. And then the gender-responsive care is not actually the norm. You have healthcare workers' response to gender inequities. It's not standard practice, actually. Then under remedies and accountability, we have the systems for reporting accountability and redress for right contravention not yet in place. Laws that protect the rights of people affected by TB are also not yet in place. On the key and vulnerable population, there were issues with access to TB services. It is still suboptimal. There are a number of key and vulnerable populations that have not been reached yet. Then data remains inadequate on this particular KVPs. In conclusion, I'd like to say that project results have shown improved access to TB prevention and care services among key and vulnerable populations, especially for women and girls. This is coming from our intervention among the refugees, nomadic pastoralists, and internally displaced persons. CRG-related barriers are being addressed. TB case notifications has improved among targeted populations, as I've demonstrated among the refugee. The implementation of TB prevention and care in the context of CRG is starting up among KVPs. We're about to conduct a size estimation right now across a number of countries, and this is going to further shed more light on the status, on the size of the KVPs to make our interventions apt. We also included operational research on how to operationalize CRG implementation. So it is not only for one key and vulnerable population. This research is going to help the engagement of a number of key and vulnerable populations. The engagement and involvement of community leaders from key and vulnerable population has improved so much. They are now involved in the design, in the monitoring, and in the evaluation of the projects we implement. They also participate in community-led monitoring. They also advocate for local priorities and needs and barriers that they face as a community. They have high interest in community meetings and dialogues and resource sharing. They want to hear how we're doing. They want to get feedback on the intervention. They want to see how we are affecting people. So CRG has the potential to accelerate our journey towards ending TB. So, like Kinza said, the time is now. We all have to see this link between CRG and ending TB. And without going into CRG, without identifying those factors related to community rights and gender, I don't see us reaching the end of TB by 2030. I would like to acknowledge Stop TB Partnership, most importantly, Challenge Facility for Civil Society for supporting this work. TB Reach also contributed in engagement of the nomadic people. Then the Global Fund, World Health Organization TB Network, National TB, Leprosy and Borreliosis Control Program in Nigeria. Then the 2 programs from the 2 states where we're implementing, Adamawa and Taraba State. And then, of course, the Bridge Health Development Center, which piloted the One Impact in Lagos. Thank you very much.
Thank you very much, Stephen. I appreciate very much you share your experience. Next, I would invite our closest partner and friend, Sabia Sachi, who is leading the partnership in Dure Technologies. Stop TB partnership was created by different constituencies. We have governments, we have civil society, we have TB-affected community, we have donors, and also we have private sector, quite extensive part of our board. We act as a convener of all the partners together. And being in 21st century, we need to use the 21st century technologies. We cannot do things with 18th century technologies as we are still doing in some parts of TB response, like diagnosing TB with microscope. This is why it's very important when we talk about community rights and gender, we also talk about technologies and so on. And I would like to invite Sabia to present some experience from the perspective how we can bring 21st technologies to TB response nowadays. Sabia?
Thank you, Viral. First of all, I feel very nostalgic. One is obviously that we are meeting after a long time, and Union happening in person after a long time. But I'm also feeling nostalgic because this is where it all started, I think in 2016 in Liverpool, where I think as a very informal discussion with one of our partners from Tajikistan led to the conceptualization of this platform and not just a platform but a whole new approach of doing CLM. That's where it started. I remember the first union where we presented in Guadalajara in 2017 with one country, and I'm very, very proud to share that we all came together, and I'm looking at a lot of our partners sitting in this room, be it Olia, I think she was just here, and Deborah from Nigeria, or Harry from TB-HIV Care, Chamroon, Edward. Sorry, Bertrand is hiding there. I can see him. So the idea of this and whatever I'm going to present in terms of what the tool does is it was really conceptualized by the communities we are supporting in the countries. How it needs to be used for the countries, how the communities need to engage with the national programs. Everything that we do came from the communities. And just to share some of the consolidated learnings from the countries, when we started, to be honest, we had no clue because the knowledge was not sitting between Dure or Stop TB. It came from the communities when we started working in the countries. I still remember the workshop, the first workshop which Kiva and I attended in Tajikistan in 2017. This is where a lot of brainstorming and learnings happened, and what we continued learning and listening to our communities what is really needed. And one of the things that we are doing differently and where we are seeing the real innovation is we are moving from a conventional CLM approach where you're just going through an outreach model and you're collecting data. It's not just about data. It's really empowering the communities where the affected communities, the affected TB community themselves are actually reporting on these service barriers, stigma, requesting for support services. So it's really bottom up where the services are accessed by the affected communities at their doorsteps. There's a lot of focus on response, so it's not just data collection. So we also learned that unless we create or strengthen the response mechanism, it's not going to work. So there's also the tool offers a response module through which the peer support group network can actually look at the challenges that are being reported by the communities and can actually provide real-time action and response on the ground. We also realized as we started working is that it's not just about data collection and response, but also we need to engage with the communities. We need to build their trust so that they can actually use this tool to maximize the use. So we also added a lot of features in terms of social behavior change communication, near me functionality where they can actually access all the health facilities on the platform, etc. There was a lot of focus on CLM data use, and I was part of a panel yesterday, and they were talking about, we don't need another randomized control trial to know that there is hunger exists or stigma exists. And I think this is really what we are trying to change, that we are not just talking about that these issues exist, because we all know these exist, but to really inform the national programs, the community champions to specify that what is the cause of these challenges, where it is happening, so to be very specific and action oriented, so that we can actually look at the data and take specific action on it. And obviously one of the approach, and we are also very proud that we have been able to institutionalize One Impact within national program. So national program now considers this as one of the key intervention to improve their programmatic target as well. So as a result of all these learnings, we have developed a digital One Impact CLM framework, and this is what it looks like. So as you can see on the left side, you have the communities who are the affected TB communities who are actually using these tools. The tools are available on multiple channels, starting from social media to smartphone to non-internet based channels, so that we can really maximize the reach. Even a person sitting in a remote village in either Tajikistan or Pakistan or India or Indonesia can still use this platform. It has multiple features in terms of it provides different services, starting from social behavior change communication. People can report on service barriers, community forums. We have now 24/7 AI-based help desk. They can access their nearest health facilities and so on and so forth. And we also have a concept of CLM data warehouse, and because we believe in that this is not the only tool which people need to use, or we do understand that a lot of people might not have access to mobile phones. So even if the CLM data gets collected through different mechanism, it can still feed into the same system, so that when the national programs or the community leaders looks at the data for advocacy or evidence-based policy, they can still look at a holistic consolidated data. Just to break down a little in terms of its core components. So obviously, there is the end user module, which is again multi-channels. You can use it on multiple channels. It has conversational AI through which, and conversational AI not just a chatbot, but you can actually, it's voice enabled, so you can actually speak to the app in your local language, in your local accent, and it converts the unstructured data into structured data to inform what the gaps. It has a dashboard. There are also slides coming, following the slide, where we'll be going a little more detail into each of these aspects. There is a response module, like I mentioned, that where the community networks can actually look at the issues being reported, and they can promptly take action on it. And there's also a smart configuration setup where the country teams can actually constantly evolve this platform based on their country-specific needs. we also know that technology, just having a robust technology is not enough. We have to constantly focusing on how we can maximize its reach. So we believe in this strategy of reach, retention, and engagement. So how do we, first of all, make this platform discoverable so that more and more TB-affected communities can know about it? Once they know about it, how, what we do in terms of so that they continue using it, and how we bring different stakeholders, starting from civil society organizations to communities to the national programs all together into one common platform. So that's the engagement part. Now, going back to the innovation part, we already talked about CLM data warehouse. Again, just to elaborate on the concept, so the way it works is that one impact obviously could be one of the tools in the countries, but we do know that a lot of countries are already using different tools. It could be a mobile app, it could be an Excel tool, but the idea is that since it's a country-led strategy, the idea is that the one impact should be able to consolidate all these information coming from the communities, irrespective of what tools they're using, into one common platform, so that the national programs and the civil society organization can have a meaningful dialogue and can take evidence-based decisions and actions. We are using a lot of AI-based technologies, natural language processing, like I mentioned, where unstructured data can be converted into structured indicators. So, for example, as a TB patient, I might have my own way of sharing my challenges. It could be very complex in nature because I'm using either text or a voice message. I could say, "Oh, I was stigmatized in this particular facility. Plus, I don't have drugs." But what the technology does is it understands these complex unstructured language and converts into a structured indicator so that specific actions can be taken on those challenges. We are working on this hybrid model where we do understand that though we are working very closely with the civil society partners through our challenge facility grantees and implementers, but if we have to take it to a national scale, we know that we might not be able to respond to every individual needs. And so we came up with this idea of hybrid model where even if we don't have wherever we have response capacity, we will allow certain set of questions to be asked, whereas where we don't have response capacity, we should not deprive the affected communities with other other services like information or near me, other things, or they can in fact also provide feedback which might not have a response trigger to it, but they can still use this platform. We also have worked a lot on the dashboard because that was one of the key aspects. How do we really use the data or information or insights that is coming from the communities to make decisions on the ground? So it's not just working in silos. It's not we versus them, but really how to make the community-led approach as one of the core interventions of the national program. So we also try to triangulate the community voices and how it is impacting the programmatic indicators. For example, is stigma impacting treatment discontinuation and hence impacting some of the core programmatic indicators, and to what extent, right? Again, we can go on and on the dashboard because it has really evolved based on the feedback from the community to a large extent. I think Kiwan, we would have, with the community, would have spent 10,000 hours to improvise and fine-tune the dashboard. And I think right now what we have, and it will constantly evolve, is quite comprehensive, where the national program, the community partners can really understand what's really going on. So for example, a national program manager can see, out of my 10 or 100 facilities, these are the 4 facilities where I'm seeing constant stigma being reported. And it's not just like going back, it's not just generic information, but I should be able to take action on it. So right, so if I can be more specific, because these are action-oriented data. If I can give more specific information as an NTP manager, I can say, let's have a training program in these 4 facilities. And we have seen wherever this happened, we can immediately improve the outcomes. For example, work we are doing in Nigeria or Mozambique, where we are using this tool for childhood TB, where the patient themselves the active TB cases can report on their children below 5 years not being screened for TPT. We are able to generate reports and immediately put them on TPT. So these are not just working in silos, but to really use community voices to improve the programmatic targets. And obviously, because it is used by the communities, we focus a lot on having a human-centric design and UI. Technology is something, a lot of time people can be skeptical about in terms of data security, privacy, this, that, right? So since we have been working in this space for a very long time, we have kept all those things in mind in terms of our technical consideration. Obviously, in terms of data privacy, security, most of the country, I think we planning to have this hosted in the local servers. It's obviously open source for long-term sustainability, because the entire data ownership, the ownership of the platform lies with the country. And obviously it is interoperable with the existing country data ecosystem, be it DHIS2 in some country or standalone data ecosystem that the countries might have. The way we have developed the platform is that we have a global template, and the global template keeps drawing feedback and learnings from different countries, and so the global platform becomes sort of the master version of OneImpact. And then once we have perfected the global platform, we sort of pass on that enhancements to the country-specific versions. And right now, obviously, we are using it mostly for TB, but it can easily be extended to mental health, COVID, NCDs, HIV, because we know that these challenges are complex, that most of the TB patient has comorbidity factors, so it can easily be extended to other programs as well. And one of the biggest benefit, like I mentioned, we have a smart configuration setup, which allows the country teams to constantly evolve the platform based on the country-specific needs. And it's not just about developing the platform, but we also have a process. This is a simplified process. I think Kiva has a very long diagram which shows step-by-step onboarding process, training process. We have an implementation plan, which is there on the OneImpact website as well. But the idea is it's not just good enough to have a robust technology, but unless we have a implementation, we apply implementation science, it will never be maximized. Thank you so much. I just wanted to also share that I've also been listening to a lot of panel discussions in this union, and usually the speakers say, "Oh, if you want to know a little more about what we do, come to our booth." But I'm very humbled and very proud to say that now, if I have to say that if you want to know more about OneImpact, you can go to Ukraine booth, you can go to Nigeria booth, you can go to the PASI booth, you can go to Stop TB booth, you can go to, we have at least 15 to 20 booths where people are using OneImpact. So thank you so much, everyone.
Thank you. Appreciate Sabia very much. I have a number of questions, and I guess we are quite well in time. We have another 20 minutes or so for questions and answers. So let me start by a question from Daniel Datico. What is the status of practical integration of community rights and gender into NTP work with meaningful engagement of community? And I'm here looking at Kiva to answer that.
Daniel, thank you, Daniel, for your question. So I think the starting point, I think, would be the natural starting point, I think, is the community rights and gender assessment. And with all of the different community rights and gender research tools, what we encourage is that there is a collaboration between affected communities and the National Tuberculosis Programme from the get-go. Because we know that the National TB Programme provides 99% of the services, and therefore their engagement in this process is critical. However, what we're also trying to change, I would say, is that the communities take a leadership position in everything that is CRG related. We know that communities can lead the research process. However, for example, what might be required is a particular expert on human rights or gender or other areas. And therefore, the starting point is we use a phased implementation process, for example. And it begins with a national orientation. Therefore, the experts, the communities, and the NTPs come together to discuss, why do we need to do this? Why do we need CRG? Why do we need to conduct this research? So you build a common understanding between the different partners, community, NTP, and other stakeholders. Then the communities can take the leadership in terms of implementing activities that have been agreed upon by NTP. The communities collect the data. They analyze that data, perhaps with expertise. Then the NTP can validate that data. Everybody agrees upon that data. Everybody agrees upon next steps and the actions that are required to address the issues that have been raised. So from the beginning, using a phased and implementation science-based approach, I would say, communities lead with strategic guidance from NTP throughout the entire process. Thank you, Daniel.
Thank you. So consensus building, then common implementation, then validation, and partnership between the community and NTPs. I have another question from related to Pakistan experience from Darcy. Have you seen any positive spillover effects for access to health services in general as a result of your CRG efforts in Pakistan? Are there certain populations that are more challenging to engage, and how have you reached out to them? The first one, have you seen any positive spillover effects of the access of the health services as a result of your activities?
So in terms of the improvement in excess of our interventions, when we say we have been screening key vulnerable populations, one of the examples is we started with screening key vulnerable populations like coal miners at the coal mining sites. To our surprise, we were unable to find people affected by TB at the coal mining sites. The incidence was equal to general population. The global literature says that the incidence is 10 times higher. We were surprised. We sat with the program. We sat with our advisors in the partnership. We said, like, we don't know what's going wrong. Why are we unable to find the people with TB? And we engaged into a dialogue with the communities. And we became aware of this thing that upon falling ill, people like coal miners, their yield reduces. They are paid by the kgs of coals that they extract. So upon falling ill, they are unable to yield that result, and they are given a month's or a day's paid and told to go back to their homes and then come back when they feel well. We started tracking where their homes are. We landed in a district called Shangla in Khyber Pakhtunkhwa province of Pakistan, and we found out that 70 to 80% of the coal mine laborers are basically coming from this one district. We started screening there, and the results of the global studies were validated. We were able to find a huge number of cases. There was not even a single household in that area where there was, which didn't had a coal miner in it, or had a coal miner or somebody whose health has not been affected. Someone has huge kind of silicosis and they were not able to perform, or someone got a disability. Some were affected with such kind of disease that they cannot now go to the coal mines, rather they were performing chores like cooking and all. So when we reach out to the populations, assess and understand those populations, work hand in hand with those populations, we know their barriers. We are able to work an approach where they are basically at the lead and we are just the supporters together. So yes, that has yielded appropriate results. And when we talk about key vulnerable population, what was the second part of the question? So we have done this prioritization as part of our community rights and gender assessment, and certain populations that have came out as key vulnerable populations in Pakistan include coal miners, transgenders. There are certain studies, the incidence is quite high, refugee population. The recent surprise was madrasa students. We have these religious schools where a lot of thousands and thousands of people are in one condensed setting. The incidence there is high. We are currently screening in prisons, and the number is quite high. Then there are certain work going around the people living with HIV, even the household contacts of people affected by TB. So we have prioritized them based on, number one, the vulnerability, and then the size of the population. Thank you.
Thank you. The next question is related to Nigeria experience from Olive Mumba. Could you share more on the uptake of TPT by children as an issue that was highlighted by OneImpact? How was the issue identified? How was the issue raised to the point of change in policy?
Thank you. TPT. Yeah, of course. TPT has been a huge challenge for Nigeria as a country, especially, talking about children. And we have struggled with this for a long time until we came to the point that OneImpact was actually launched. So despite our program efforts, there was a point that we reached that we couldn't cross. But when OneImpact came with the implementation that happened by the bridge in Lagos, there was access to children, to mothers, which encouraged this particular enrollment of children on TPT. So I can see Deborah is here. She implemented this particular OneImpact in Lagos, and then she can tell us more about what happened. We have the numbers in the presentation, as you can see. So over to you, Deborah.
Thank you, Dr. Stephen, for a very brilliant presentation you made earlier. It was as good as it was you who, implemented that. So children were placed on TPT based on information that we were able to generate through the OneImpact. And how did we do this? At the point of onboarding people on the OneImpact, when people identify as a person with TB, then the app goes ahead to ask them, do you have children? And when they say yes, it even goes ahead to ask them, do you have children below the age of 5? So that we're able to also identify priority groups and all of that. And when they go ahead and say yes, the app goes ahead to ask them, have they been screened? Yes or no. And then when they say no, there's another line of questions. And when they say yes, they've been screened, it still goes ahead to ask them, have they been placed on TPT? And when they say no, all of this information is filtering into the OneImpact dashboard. And then the lead organization and the NTP can see these gaps. And when these gaps are identified, it now makes and provides opportunity for the TB program to make informed decision, programmatic action, targeted interventions to the areas where these issues are highlighted. So for Nigeria, part of the ways that we're able to get those numbers up is that we then go to the health facilities where these issues are coming from. And then we organize interventions, right? Because TPT uptake is not just about availability of the TPT, but the question is, are these people really, really aware of the relevance of TPT? So interventions like building capacity sensitization on TPT, what is TPT, why is TPT important, and all of that helped us to convince the people to be able to see TPT as even their right and the rights of their children. So now in Nigeria, we have people going to the health facility and say, hey, I'm a person with TB. My children have not been screened. I need TPT for my kids. So that's how we managed to do it. I don't know if... Yeah.
Thank you, Deborah. Appreciate very much. The next question is from Natalia Shumskaya from Kyrgyzstan. Many women in Kyrgyzstan are not free to make decisions about starting TB treatment. Often they depend on their husbands, mothers-in-law, and other family members. Please share successful practices to overcome this barrier. I see Anna in the room, and I would like to ask to put you on the spot, to ask you to answer this. We work with Anna on gender quite extensively, so.
Viral is putting me on the spot here. I'm trying to think of where we have really successful practices to support women. I'm gonna turn to a project that we, through TB Reach, Stop TB, supported in Pakistan, and that really looked at training female doctors who are not providing TB support, because in Pakistan female doctors tend to provide maternal health services and TB gets excluded. So this project really looked at and worked with women doctors who are generally gynecologists and engaged them in understanding TB and retraining. Everyone's had training in med school, but for years they haven't been doing it. So this project really looked at doing that and working with those doctors to then access women when they came to the care that they generally seek. That was a phenomenally successful project. And then that project also looked at having women go out with the men who were working within communities, because in that area it was more, if a woman goes to a house, then they couldn't necessarily access the men. If a man goes, couldn't necessarily access the woman. So that project also looked at education and working with I'm having to go into my memory a little bit here, but having men and women access households. So when they did the community screening, it was about who went into households. So that's an example that I can pick up that has been the most successful. Yeah, I think that's the one I'm going to leave you with. But it is really looking at where are women accessing healthcare, and how can we leverage on that, and how can we maximize that? There are the bigger questions of gender equity, and I'm not sure that we've managed to grapple with those successfully yet.
Thank you, appreciate.
Yes, thank you,
Please go
Viral.
ahead.
I wanted to add another example to what Anna just said. I think there is no place in my experience where you have the negative influence or patriarchal norms in preventing women and girls from accessing service like the nomadic communities, which we have worked with for more than 10 years. So how did we change this? We cashed on the community engagement component. These are people that are conservative, and of course they shy away from the general population. They don't trust the health system, and they wouldn't want you to even talk to their women. When the women are sick and they come to the hospitals, you ask them questions, they cannot answer unless their husbands are present. Otherwise, they will just be quiet and looking at you. So it was through community engagement, a stakeholder analysis to identify the leaders who are hierarchical, engaging them to let them know exactly what we are doing. And we couldn't do this without their own. We had to identify somebody who is also nomadic, who is much more educated. And we picked on a person who has worked for 35 years vaccinating cattle, and he has retired. And of course, for the nomadic people, if you like their cattle, you are their friend. If you have problem with their cattle, you become almost enemies. So we put this person in front as a community lead. We even called him program manager, and he is a nomadic person. So he led us to all the community leaders. We spoke to them, we had dialogues, and of course, they gave us the volunteers. We made sure that we identified volunteers from the same communities. And in these volunteers, we had about 40% of them being female. So that opened the door to accessing women, and that opened the door also for the women to access health services. So this is how we're able to get the results we're getting with the nomadic engagement, which is a good example of how those CRG and the community interventions change the picture when it comes to access for women. Thank you.
Thank you very much, Stephen and Anna. Appreciate your support as usual. The next question is from Ali. Is community-led monitoring also looking at or tracking drivers of TB, such as poor mental health, air pollution, or etc.? Sabia.
Thank you, Viral. I think this is why I love these platforms, because it's also a platform to ideate and come up with these very fresh ideas. I mean, we are tracking a lot of driving factors, but not pollution at this moment. But the good news is we have this platform where we engage with all our country partners, country CLM partners, and I think these are the ideas, and especially now when climate and health is becoming so important. I think we will definitely would love to explore that with our community partners on how to include some of these transdisciplinary aspects to TB care and TB service delivery and community engagement. I think absolutely. I think this is a very good idea, and I think hopefully the next union we should be able to talk more about climate health and mental health, NCDs, and a lot more. Thank you.
And also an additional question for you from Basra Zogt. Thanks for introducing OneImpact, a great tool. Can remote population use it offline? Mongolia is a large country, and one of the healthcare challenges is geographical distance.
So absolutely. The OneImpact platform works completely offline. We also have, it is available on 2G channels. So for example, even a completely non-internet based phones can support OneImpact through USSD, IVRS, SMS. We also have something called the assisted model, where we, even the net outreach workers or the peer support group networks can report issues on behalf of the communities, affected communities. Plus, also, like I mentioned, talked about the CLM data warehouse. That even if the data, there is manual, way of collecting data, and somehow it is getting stored in, let's say, Excel, you can still upload the data into the OneImpact platform in the OneImpact CLM warehouse and still get access to those insights from the country. So absolutely.
Thank you, Sabia. And now I guess I will say it's a last question. Even I have many. Please, those questions that are burning. I see a hand. We need to finish in time because there are other sessions as well. I will give you a floor as well. The last question is for participants, for all panel, to all speakers. From Maha Farhat, can you identify some research priorities to maximize the use of community TB data for improving control? And I would like to ask you to wrap up as well. Any volunteers to start?
Sure. So in the area, community rights and gender, we have this publication, the first one on the barriers of access to care. This is sort of bringing together findings from 20 countries, but we really need more evidence for how screening in key vulnerable populations has worked. What are the barriers to access in various countries? What are when we see the right to health framework, what are the barriers that the people are facing? We need more investment and need more research work in the area of key vulnerable population size estimations, studies in key vulnerable populations. So this is a developing area. We really need research in all the aspects. And wrapping up line, we need everyone here in this room, everyone to really see the importance in community rights and gender, and this is the way forward. What got us here won't get us where we need to be to end TB by 2030. So we need to sort of really join hands and move forward.
Thank you. Besides the issues around key estimation, and of course the key size estimation of KVP population, and of course the barriers that are coming out now, because you know CRG is a new area, there are many more barriers that we don't know. In a country where you have 250 to 300 tribes, where you have cultural differences, definitely the drivers of the barriers will differ. So we're working among refugees, we've worked among nomads, we're working among IDPs. There are other populations, key and vulnerable, who have different cultural drivers, different reasons for not accessing health services. So it's not easy to run a research in just a section of a country as big as Nigeria and to apply the findings generally over all the population. So there is need to explore more of these people. And that is why after the prioritization, the next thing we're trying to do is to identify those KVPs, one after the other, to see what are the main drivers of the barriers. And once we identify those barriers, we're going to design interventions that align and then integrate them into our projects. And that way, we can continue to fight TB till we end it, hopefully, for 2030.
I think from my side, I think we need to continue investing, putting all our energies into strengthening communities, strengthening data systems, because knowledge is power, and strengthening data use at multiple level, not just at a national level, but also sub-national level, facility level, community level. So I think that would be my take.
Echoing Sabia, I think that we need to maximize now and scale up institutionalized community-led monitoring for the very same reasons that Sabia mentioned. But one additional area of research that I think we need to prioritize is around TB stigma. We have a UN HLM target on ending TB stigma. We have a tool to help us to get there, and I think we need to use it. There was excellent research conducted by Bertrand Campouer and Maxime Lunga in DRC recently, which showed that over 50% of people affected by tuberculosis were had experiences of stigma that impacted their ability to access services. 50% of people. Therefore, I think more and more countries should start using this tool so that we can really end TB stigma. Thank you.
Thank you, appreciate. And from my side, I would say that any research in community rights and gender is useful because the research proves that it works, right? So think about on everything that we are working around community rights and gender to document. This is important. People are coming back asking, including donors, those who put money in CRG, they are asking, is it working? Is it worth to support? Where is the return on investment? Return on investment in terms of saved lives and other public health effects. So that's important. Please document everything what you do because this is important. And I apologize for all those that we didn't answer questions. Please approach individually the members of the panel. We will be happy to answer all your questions in addition. Just to conclude this session, community rights and gender works. This is what we need to understand. Knowing the barriers is important. Go and do assessments of those barriers and see those barriers. Overcoming those through clear plans. Tools are there, everything is there, and it works. And we need a little bit of funding to put there. You heard that there is a very small percentage at the country level that is spent for community rights and gender, which is a very important domain to act in order to end TB. We are saying without community rights and gender, we will not end TB by 2030. Thank you very much, and thank you for the excellent panel that we had today. Appreciate it.
Just to capture this memory and the people we have been able to gather for this very important area, we'll request if everyone can just come on the stage for a minute and we can take a group photo together. Thank you so much. All supporters of CRG, please come on the stage.